I think the first point is that traditionally in patients who haven't achieved a CR with induction chemotherapy, been felt that they really have no effective treatment options. But in the last 15 years, it's become clear that allogeneic transplantation in fit patients who are failed to achieve a morphological CR after 2 courses of induction chemotherapy actually can be a curative strategy, and certainly is superior to simply continuing with intensive chemotherapy. I think using the classical criteria for primary refractory AML, in other words, failure to achieve CR morphologically after 2 courses of induction, essentially further intensive chemotherapy is futile. But 25 to 35% of patients can survive long-term after an allograft. So I think this is very important to bear in mind for selected patients. There are clearly patients with refractory disease for whom this is not a suitable option or not deliverable. And we also need to work as a community, I think, to identify which patients with an allograft with primary refractory AML actually do well. Maybe it's those with some element of chemosensitivity, or maybe there's a particular biological subgroup. And I think the other area of active discussion concerning the benefit of achieving CR in the patients who are going to go to an allograft is discussing in more detail what's a good CR. So we know that pre-transplant MRD the presence of pre-transplant MRD is associated with an increased relapse risk after an allograft. There's retrospective data, but there's now prospective data from the Figaro trial, led by my colleague Sylvie Freeman, and also from the Chris Hurricane data, where it didn't use conventional MRD, but just demonstrated that the presence of by NGS of molecular mutation was again associated with increased relapse risk. I think it's very important because those 2 studies, Figaro and the Hurricane study, were actually prospective study. Many of the data that's quoted is retrospective study. The impact of pre-transplant MRD on relapse varies wildly, and we have to be thoughtful about the importance of prospective data sets to give accurate data. So what we know is that if you have got pre-transplant MRD, your risk of relapse is higher. The question then arises, should you go to transplant if you've got pre-transplant MRD? And I think the important data from the Figaro trial we published in JCO last year shows that although the presence of pre-transplant MRD increases the relapse risk at 2 years from 20% to 40% and reduces the 2-year overall survival from 70% to 50%, in fact, a significant number of patients transplanted in morphological remission with pre-transplant MRD achieve long-term disease-free survival. So I don't think there's any evidence that if you've got pre-transplant MRD and you're in a morphological CR, you shouldn't proceed straight to an allograft. And in fact, there's no evidence in my judgment that further courses of intensive chemotherapy will do any benefit. They may do harm. Clearly, we need randomized studies in this area. But at the moment, I think if you've got pre-transplant MRD, your route to cure should be through a transplant. And there's a very strong case for getting on with a transplant as soon as possible. And then thinking possibly about optimizing the conditioning regimen. So if you've got a patient with pre-transplant MRD, you'd be favouring a myeloablative conditioning regimen over a RIC. You'd be favouring an earlier taper of immunosuppression and possibly favouring maintenance therapy.